Hello and welcome to the Nurse Rosa's Insights podcast. I'm your host, Rosa Hart, and today I am joined by Alicia Richardson. Thank you so much for being with me today.
Thanks for having me, Rosa.
So I am honored to have such an illustrious person on my podcast. Just kidding. Everyone is illustrious that I have on this podcast. but But yeah, you have a whole lot of things I could brag about you for, but you've been a leader in the ANVC, like Rhonda Finney, who I've had on the podcast ahead of you. And you also have been with SVIN, correct?
That's correct.
Yeah, and then what I'm really excited to hear from you about today is also your work with the World Stroke Organization's Future Leaders Program. So, girl, you get around internationally in the stroke world. So,
Yes, it's been very eye-opening for me to be part of the World Stroke Organization. I first became aware of this a couple of years ago that they were doing their second cohort of people selected from all over the world, about 35 to 40 people. They're specifically looking for younger leaders in stroke who are interested in research and basically carrying on and being mentored by other world stroke leaders so that they basically grow new leaders across the world for stroke. I interviewed for a position on the cohort for the Future Leaders Program and was selected. And was very happy to be selected. There were 2 people from the United States, and then otherwise the rest of my cohort was all across the world, and really tried to be, you know, people who were in underserved areas of stroke as well. And so some countries who, don't have great access or more rural or just are deprived of resources from a stroke care perspective. So basically, the program was 2 years long. And in the program, in order to graduate from the program, you have to do a research project that is focused on a disparity in stroke care. And you work with your cohort members across the world to work together to improve an area of stroke care. And so my group was the Tanzania project in sub-Saharan Africa. And it was basically a continuation of cohort one's project in improving the same focus was sub-Saharan Africa and developing stroke units. And so we developed a curriculum of education and we built a couple of stroke units in Tanzania in this project together as a team, basically giving virtual education to their staff in those hospitals and helped them to become a stroke center. And so it was a really wonderful project that was very rewarding and fulfilling. I learned a lot from doing it because you don't realize until you're, talking with others, how good you may have it in your own country, from a stroke care perspective until you start, learning what others don't have. And how much you can do as a group really when you get together with people from all over the world and try to, put resources into one location to try to build up their stroke services. So we basically brought them from minimal services to essential services in those regions. And so we're really, really proud of the work that we did in such a short time in that program. So,
wow, that
yeah.
is so incredible. And so, did you ever go to Tanzania?
No, sadly, sadly,
Not
and that
yet.
was actually right. And that was actually very difficult to not um, be able to connect with the people that are working there and try to, make suggestions and implement things when you aren't familiar with the culture or, the needs. And so that was one of the most challenging pieces. But the fortunate thing is the lead of our project was from Tanzania and was local to the area. And so she was very much our resource to, connecting us to different people who could help us understand what current state looked like, make sure we did appropriate needs assessment and all of those things so that we understood, as best we could without physically being there.
That is good. At least somebody was there because also it's hard to get other people to be involved if no one is
Mhm.
on the ground, essentially. That makes me feel so curious, and I could ask a million more questions about just that, but let's start over a little bit and go back to your background because you're
Sure.
coming from a nursing background, correct?
That's correct. So I first started my nursing career on a neurology med surge unit. So I've always been a neuro nurse, never left the neuro space. I became a clinical nurse specialist and stayed on that same unit before moving into stroke specific dedication as a clinical nurse specialist for a stroke program in Penn State Health. Hershey Medical Center is where I work now. I transitioned into a more of a leadership role within the program as the stroke program manager, and then more recently, 2 years ago, moved into a system leadership position. So now overseeing our whole hospital system and the stroke programs there. And I became involved with ANVC probably back 10 years or almost 10 years ago now at this point. So I first joined as a board member and then transitioned into the president-elect role and then into the president role. And since you already met with Rhonda Finney, you know that she will be taking the president role from me in just a couple of months, really, in November. So
Wow.
yeah, it's
Yeah.
been quite a journey.
So did you join that before you became a clinical nurse specialist or?
No, that was after. So I actually did what's called the NetSmart program. So NetSmart is an advanced practice fellowship program for non-physicians.
No.
So advanced practice PAs, nurse practitioners, CNSs can do this fellowship-based program, which basically trains you at the level of a vascular fellow. And so I did that program first, and then that introduced me to ANVC because I became board certified as a advanced neurovascular practitioner.
Now, does that mean you do intravascular interventions?
No, it does not.
Okay.
So
So where do you draw the line?
so it's really more about the knowledge of basically working a stroke patient up and treating them. So it really helps elevate the practice for APPs if they are maybe managing stroke alerts in their hospital and the ones to make decisions about thrombolytic or neurointervention. That's where it becomes really valuable, is to have that background knowledge, especially if you work in a setting where maybe you're the only APP that's responding to stroke alerts, which we have a lot across the country that kind of function in that capacity and have to be the person who's responsible where there's gaps or um, limitations in how much neurology coverage places have, because there's certainly a shortage of providers.
Yeah, that's really great. You got to participate in a program that had a fellowship dedicated to that because I know in a lot of
Mhm.
places you're hired by the provider and they train you to do what they want you to do essentially. And it's not like uh, I don't want to say regimented, but it's not like a program that's been worked out. It's very provider specific, wouldn't you
Yeah,
say?
and this is very curriculum based, and it's a self-paced type of learning platform, and then testing along the way with a mentor of a vascular neurologist at your site. And then the last week you actually spend doing an on-site clinical in order to graduate from the program. And I actually got to go abroad for that as well. So I went to the UK and was able to spend some time at hospitals in the UK area, and learned a ton about stroke care being delivered there as well. So that was kind of one of the things that made me interested in more of a global approach as well to stroke care and understanding different places and how we manage care across the world. So
Exactly.
it was
Because
fascinating.
I mean, as humans, we have a whole lot in common, and you would think we would just treat everything the same way. What do you think was the most surprising to you when you were in the UK learning how they approach stroke care?
So in the UK, I was there probably 6 years ago, I think at this point, 6 or 7 years ago. So things have changed probably a bit since I was there. But when I was there, I was very surprised at the lack of access to interventional care. So like a thrombectomy for a stroke patient, for example, they only had coverage during like the daytime hours for patients. And so if you had your stroke at the wrong time, you would not get intervention. And so I remember there being like a 35-year-old patient who was clearly having a large vessel stroke, who only got thrombolytic and was not able to be transferred to a higher level of care for neurosurgical intervention because they just didn't have it at that time of day. And I was thinking, my gosh, if we were in the United States, this, now granted, we do have some issues of access in the United States as well,
based on
but for the
location.
most part, we would have been able to do that intervention on that patient. And now they're left with, devastating disability from this big stroke. And so I remember the access being very surprising to me. I thought that they would have wraparound 24/7 coverage for that, and they didn't at the time.
Well, tell me if I'm remembering this right. Is it other countries like the UK that expanded the intervention hour like time window
Yes.
before we did? Do you think that availability like that had something to do with them being interested in expanding the intervention time frame sooner?
I mean, they still struggle a little bit, I think, with access. So I'm not sure that that really is necessarily linked to it, but yeah, it definitely could have impacted it for sure.
Yeah, I mean, we were very, you know, much hopeful that expanding the intervention window up to 24 hours and
Hmm.
hypothetically beyond, I'm sure on a penumbra, case by case basis, you know, gives more people hope. So,
Right, exactly.
whether the issue is people aren't scheduled or you're just so far out, right? Like I was speaking with a doctor out in Montana where it may take several hours to fly somebody to the
Mm,
nearest place. So, we definitely have our own care deserts here within the United States, and
we do.
so,
We're actually working on a project that kind of stemmed from some of the members in the World Stroke Organization Future Leaders group that I'm in called Map Stroke. And
yeah.
Map Stroke is looking at mapping the whole globe of looking at where we have access to services and where we might be lacking. And we're working on mapping the United States right now because we do feel like there probably are pockets of the United States that it does take multiple hours to get to the next level of care. And so can we work with policymakers and state representatives to say right here in this spot of this particular state is where we're takes over 30 minutes to get to a stroke certified center with access to thrombolytic or thrombectomy. And so trying to really improve that access is so important, and I'm excited for to see what that project will show us once it's done mapping the United States, because I do think we have some opportunities to have some better stroke care in more rural areas.
Oh, definitely. And, since you had that experience working so closely with the team in Tanzania, um, I'll ask you again, what surprised you about that experience and how stroke is in their community?
I think what surprised me the most is that thrombolytic is not, the cost of it does not match the cost of living for patients. And in many of the centers, you were not able to get the thrombolytic until a family member went to the pharmacy and paid for it beforehand.
Oh, gosh.
So yeah, and it's very, very, very pricey. So most people couldn't afford it, and so they would have to just not be able to give thrombolytic if they couldn't pay for it up front. And that really surprised me. I did not expect that to be something that was built into the process and expected of patients and families is to go pay for their own thrombolytic before it can be used. And just all of the delays that are associated with a process like that, and
Well,
just
and
not making it affordable for people.
they have to be convinced to even want it in the first place, and usually
Exactly.
we're more concerned with how much time it's taking to convince them to just say, "Okay, so we can give them the IV push," you know? Or if
Not even things we think of, right? We just go ahead and proceed. We don't think about things like that. And the model is very different. And so we had to work with like the health ministries and try to make sure that thrombolytic would be covered and um, not at the expense of the patient's family and whether or not they could afford it.
yeah, I mean, gosh. Yeah, that would be devastating.
Hmm.
So another thing about looking at it from an international perspective, I know, um, a lot of times it seems there's stigma around stroke because it can be one of uh like heart disease, kind of like, a sin disease or something, or like
Mhm.
because it's associated
Preventable.
with, or it's preventable. It's associated with obesity and smoking and things like that. And so a lot of the times you might hear people say, "Well, you just need to eat right and exercise, and this wouldn't be happening to you." But in a lot of the other parts of the world, I assume that they may not have the same risk factors contributing, right? So when you were in looking at Tanzania or even other countries, as you're discussing this with stroke leaders around the world, what did you see there?
I definitely learned of some different risk factors that I didn't realize were risk factors for those particular countries. Like air pollution is a big one in a lot of other countries, and
Hmm.
I didn't even realize that that was one of the stroke risk factors for them. I also learned that hypertension is a much different, just a different problem with the different backgrounds that people have from a racial perspective, and how many more hemorrhagic strokes they have versus ischemic. So we typically see about 88% ischemic, 12% hemorrhagic stroke, and in some places it was 50-50 there. So very different from a hemorrhagic perspective from the hypertension that's experienced. So that was very interesting too, because we don't see that many hemorrhages, but we have better primary care and better blood pressure management. Even though we still think we have a lot of work to do with hypertension, of course, but it's not as bad compared to some other places who really struggle with that primary care aspect of prevention and primary prevention.
And when you talk about pollutants, why is it worse for them in these other countries? I mean, I assume this is specific to certain industrialized areas that you're talking about.
Yes. Yes, it was. And they just believe that it's like an inflammatory process, that it's just damaging to the arteries and causes an inflammatory response and puts people at risk.
And do we also
Um,
see this in American cities like
yes,
LA, New York, big
yes, yes,
places? Yeah.
yeah,
Okay.
yeah.
Wow. Yeah, it's not something I think about in rural Kentucky very much, but
No, me neither. Not in Pennsylvania.
our big air pollution, like I know we have some air pollution or something, like they put an extra 25 cents per gallon on gas in Louisville, Kentucky to like control emissions, hypothetically, I think. Um, but the real pollutant feels like it's the pollen because I don't know if this happens in Pennsylvania where you are, but in the spring, all the cars and buildings are like covered in a sheet of pollen, and there's
Yes, we have the same
definitely an
thing.
inflammatory process happening there.
Oh, yes,
These
for
allergies
sure.
are crazy.
Mhm.
So, so I would love to ask you some more about I love how, in your case, you have been deeply involved in several different key organizations. And I feel like, in my experience with nurses, they like to pick a nursing organization to volunteer their time with and really pour into that one and feel disloyal maybe if they go spend time volunteering for another one, almost like you're cheating on your church or something,
Yeah.
as a Southern expression. But I know I, for one, have really benefited from visiting different groups and exchanging ideas in different subject matter. So, can you explain to us kind of what the ANVC is, what SVIN is, and what the World Stroke Organization is, in how they're different from one another?
Sure. Yeah, so ANVC is the Association for Neurovascular Clinicians, and ANVC is really focused on non-physician groups. So looking at vascular specific things like stroke coordinators or advanced practice providers that are in a vascular neurology or neurosurgery role, stroke leaders, stroke like program managers, those kinds of roles, as well as the neurointerventional space. So the RNs and the radiology technicians who work in all of our interventional suites is really who makes up the ANVC from a membership perspective. So it is membership based organization, international as well,
Mhm.
and really is very focused on the education and preparedness of our our membership. And so we really do a lot of educational activities to make sure that we're really elevating the practice, because we really believe that knowledge is power, and that it's really important to make sure everyone is has the highest level of knowledge that they can surrounding this patient population, so that we can improve stroke care. And so that's really the mission of ANBC. And then SVIN is the Society for Vascular Interventional Neurology. And I started working with them several years ago as well, from the advanced practice side of the role, and really became interested in their organization, as well as SNIS as well. That's another organization that I'm involved with.
What is that?
Both of them, SNIS is the Society for Neurosurgical
Oh,
Interventional. So there's a neurology side and a neurosurgical side that both do intervention on stroke patients. And so both organizations are very similar, but it's more the physician side of things. And
ah,
so they have a smaller nursing components to their organizations. But as we all know, nursing plays a huge role in these stroke patients. And so I think it's important to be involved in those societies as well, to really make sure that nursing has a voice, and that we're well represented. So I've been on their education committee, and enjoyed my time there, making sure that advanced practice, especially in the IR space, is represented. And then the World Stroke Organization is really that global picture, of course, of making sure that we have good access to care and are thinking about disparities in stroke care. And I really became involved with them when I joined the Future Leaders Program. And that being involved in the World Stroke Organization, I think, has really opened my eyes to so much stroke care across the world, and made me very passionate about that. And I definitely have an interest in continuing to make connections across the world, and make sure that we're, kind of elevating all that education and sharing it with other places across the world that don't maybe have access to that. So I'm hoping that, a lot of these organizations have overlap with one another, and they share similar visions and missions. And so I feel like, when we cross over different organizations, we can do so much better together,
mm,
really. I mean, it sounds cheesy to say that, but there's a lot of overlap, and we're all trying to do the same thing. And so it doesn't need to be that you pick one organization and you just stay with them. It's wherever you feel like you can benefit, and you can benefit others by being a part of the organization. So
yeah, exactly. I mean, how else are it's amazing to me how we can get so siloed, and like maybe one group is like building this wealth of knowledge, and then other people never hear about it because they're busy staying in their lane.
yes.
And they're like, "Oh, I wish somebody would do something about this," and somebody is doing something about it, but
Right,
because
right.
they don't necessarily intersect, um, they might not know, and they're trying to
Hmm.
reinvent the wheel over here,
Right,
right? I don't know,
right.
maybe we could use AI to, help streamline communication in
Right.
some way. That I'm trying to look into different ways we can use AI to break out of our silos and improve communication across specialties or across disciplines. And because I think there's so many times people would talk to each other, they just don't
Yeah.
know who to start with
Right.
or where to look.
Yeah, exactly. Yeah, and I'm a big proponent of making sure that we don't reinvent the wheel, and a big sharer. So I really strongly feel like that there's not really competition in stroke. Like I can't stand when people become like territorial over stroke patients, because I feel like we shouldn't think of it like that. We should be all helping one another to make sure that stroke care, like, there's enough stroke patients to go around, sadly, that there's enough.
You're
And
taking the words right out of my mouth.
yeah, and so might as well help other people not reinvent the wheel, and what works well at one place could work well for another place, and best practice share. So
Mhm.
I think that's really important. And especially when you think about, how many of us travel all over the place. We want good stroke care wherever we go. We never know if we
Mhm.
might be the one, or our family might be in the one where you need that stroke care, and you would hope that another hospital, you know, had the resources and someone shared with them ways to improve, rather than say, no, 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 You're our competition. So
Like, how many times you tell me, and so I'll know how weird I am. You tell me, how often when you go on vacation do you look for the nearest comprehensive store?
oh, I do. I do
Every single
definitely.
time.
Yes. Yes, I do.
Like, I was in Barbados, and I was like, "Okay, what's the nearest place?" I'm like, "Well, it is next to a med school, so
Mhm.
there's hope."
I know it does make us a little paranoid, huh? Like, because it's important, especially when you start learning about what the world, what the access is to care in some places. You're like, maybe I won't vacation on that island because there's no way to get me off of that island timely if
And for
I
you
run
and
into
me,
an
that would
issue.
contribute to our stress on the
Yeah,
vacation and not be able to
for
relax
sure, for sure.
because
Yeah,
we haven't controlled
absolutely.
for contingency.
Hmm. Yes, we do.
Thank you. I feel like more of a normal person. Um,
Yeah, you're not
so
the only one.
right, leave it to stroke nurses to
Hmm.
thrive on that. Let me ask you then, we come to the $1 billion question that I ask every guest on the Nurse Rosa's Insights podcast. That is, if you were given a grant for $1 billion, how would you like to see it used strategically to have the most sustainable impact?
So I would love more primary prevention of stroke because I really feel, although we know that some strokes, cannot be prevented because of genetics or because of environmental factors or things that are, influencing the lives of patients, for the majority of the time, those risk factors are modifiable and manageable. And I think we don't do a good job with primary prevention of stroke. And we don't have good integrated networks with primary care providers to help them to even identify that a patient might be at risk for stroke.
Mm,
We did this big project in my health system where we looked at the patients who came to us within the time window for thrombolytic and the ones that came not in the time window for thrombolytic, and assessed their knowledge and whether or not they went to a PCP and we're regularly, following up with a PCP. Multiple patients had several risk factors for stroke, were never educated on the signs and symptoms of stroke, of course, then had symptoms of stroke, had a stroke, and came late for thrombolytic. So I feel like even though we do a really good job in the hyperacute phase with all of our interventions that we have now, we still haven't wrapped our arms around how to prevent them in the first place and how to really reach the community, make sure they understand the signs and symptoms, make sure the PCPs are, you know, robustly educating and screening people for stroke and managing risk factors appropriately. I think that we could just make a huge difference just by primary prevention, as simple as it sounds.
mhm. And I was just listening to another podcast the other day. I think it was from the founder of Hippocratic AI. I can't remember his name, don't tell him. Um, but he was talking about how oftentimes we say an ounce of prevention is worth a pound of cure in cost savings. And his point was that's true, but then we're not accounting for the cost of that prevention, of that education, of the providers giving up their time to address those issues that are not the emergencies that are, really crying out for attention. And so there is an upfront cost. And so it's not that there is no cost. And so that was one reason I was really interested in, how can we utilize tools like AI to exponentially increase our amount we're able to do education. And you tell me if this has been your experience as well, but I've called a lot of stroke patients for, follow-up education. And when I was seeing
Mhm.
them at the bedside, um, they would say, I didn't have high blood pressure and diabetes before I had this stroke. I come in the
Yep.
hospital and I find out I have all these things I didn't even have before. And it's like, well, excuse me, but you did have them. You just
Right.
didn't know. And because it was out of
Right.
control, you had a stroke. And
Mhm.
so now we gotta get them under control so that you don't have another one.
Yes. Yes.
And, so that means a lot of life changes, not necessarily even just lifestyle changes, but, taking medications and
Right.
taking your blood pressure and going to your doctor appointment follow-ups if you have access and can afford that,
Mhm.
right? Um,
Yep.
and a lot of people don't care about prevention until after
Right.
they've had a stroke because they're like, "Oh, well,
Yes.
that doesn't apply to me." So, um, in doing the Stronger After Stroke podcast, I've been able to educate people in 86 countries and reach people who don't have access to come in for in-person education. And so
Yeah.
seeing that
Fantastic.
exponential increase in reach and ability to help people with technology, but not
Mhm.
in an impersonal way,
Right.
it's just really lit a fire in me to look for, well, what else are we not sleeping on? What else are we not using that we could be using to increase our effectiveness? So I'm really thankful for people like you, Alicia, who are thinking globally and information sharing so we
Mhm.
can not reinvent the wheel, but
Yeah.
actually make progress together.
Yeah, I think that's really important. Um, yeah, absolutely.
Definitely. So, if people want to reach you, is LinkedIn the best way?
Yeah, LinkedIn would be great. That would be a great way.
And then, I'll probably put links to the different organizations that you're a part of slash leading in there as well, in case anybody wants to check them out and learn more about them.
Okay.
And then, is there anything else you would like to share?
I don't think so. Thank you so much for having me.
Okay.
Appreciate it.
Well, it has been an honor to learn from you today, and I hope we'll get to see each other again at one of these mini stroke events.
That would be wonderful. Thank you so much.
You're welcome. So, if you've enjoyed this episode of the Nurse Rosa's Insights podcast, be sure to like and subscribe wherever you're listening. If you are on Spotify, Apple Podcasts, or if you're watching on YouTube, leave a comment if you've learned something and let me know if you know of another person I need to spotlight for the great work that they are doing or a great idea that they have that needs to be amplified. And we'll see you in the next episode.